So the verse of the day today is, our struggle is not against flesh and blood, but against the rulers, against the authorities, against the power of this dark world, and against the spiritual forces of evil in the heavenly realms. Therefore, put on the full armor of God, so that when the day of evil comes, you may be able to stand your ground, and after you have done everything to stand. Ephesians 6:12-13. I love this verse. Our struggle is not against flesh and blood, but against the powers of the dark world. Like, I think about it often, right? Because we're accustomed to so many worldly pressures, worldly forces here. You know, I never used to believe in this, but actually, as I grew older, got closer to God, I realized this is true. Our struggle is not against flesh and blood, but against the dark side. So stand firm and put on the full armor of God, like we're gonna do today, because we're gonna get through this. We're gonna get through step one. All right, let's go. So what we have today is decorvan thyroiditis. Um, you see thyroid follicles containing colloid, and you see multinucleated giant cells. Okay. Um, Melman, let's see what Melman has to say about this. This stuff is very high yield. Okay. Oh, let's see. Okay. So 22-year-old male with a viral infection has a very tender thyroid. This is subacute granulomatosis thyroiditis, aka decorvan thyroiditis. Uh, what you see, triphasic, causes hyper, then hypothyroidism, then rebounds to euthyroid state. Most important point is that iodine uptake is decreased in decorvan and drug-induced thyroiditis, even the patient has hyperphase. Okay, so you have to know that iodine uptake is decreased. So basically, iodine uptake is going to be down in decorvan. Um, the iodine uptake is decreased in decorvan and drug-induced thyroiditis, even if the patient is in a hyperphase. Okay, so iodine uptake is going to be down. Good. And decorvan, in decorvan and drug-induced thyroiditis. Okay. And now, the treatment for decorvan thyroiditis is NSAIDs. Okay. Um, okay. Is it? Nothing else? But why? Let's check the Pathpedia. Decorvan. Decorvan. Oh, there's nothing in the. Oh, okay. There's nothing in the Path PDF. Let's check first aid. Cover all our bases. Oh no. What's that? CT. Okay, so this is it. Subacute granulomatosis, known as decorvan. This is self-limited disease, often following a flu-like illness, like after a viral infection. May be hyperthyroid early in the course, followed by hypothyroidism, permanent in 15% of cases. Histology, you'll see granulomatosis, inflammation, findings, high ESR, jaw pain, very tender thyroid. So basically, we have a painful thyroid. Think decorvan. Just think decorvan. This answer always shows up in different forms. The answer is um, decorvan. Um let's see, endocrine decorvan. So first you see hyper, then hypo. Yeah, hyperthyroid early in course, followed by hypo. Um, the thing is, you have to know iodine uptake is always going to be decreased in decorvan, even in the hyperthyroid part of it. Okay, so gotta make a note of that here. So in Hashimoto's thyroiditis, um, Hashimoto's thyroiditis is an example of primary hypothyroidism, where you see decreased T3 and T4 and increased TSH. The thyroid gland itself is underproducing thyroid hormone. TSH goes up due to decreased negative feedback at the hypothalamus and anterior pituitary. High yield examples are Hashimoto's thyroiditis, which is autoimmune destruction of the thyroid gland, and iodine deficiency, which is insufficient thyroid hormone precursor. So what happens here is, like, let me tell you what happens normally. Normally, TRH is produced by the hypothalamus, which stimulates the anterior pituitary to release TSH. TSH then stimulates the thyroid to make T3 and T4 normally. In primary hypothyroidism, T3 and T4 are so low, so then the hypothalamus increases TRH, which makes the anterior pituitary to increase TSH. That's why you see increased TRH, increased TSH, and low T3 and T4 in primary hypothyroidism. How I remember this is that I think of hypo, and I think of automatically hypo. So what's hypo? What in the thyroid? I would think of T3 and T4. So because the thyroid gland makes T3 and T4. So in hypothyroidism, I would think low T3 and T4. And if T3 and T4 are low, that automatically means TSH is up. That's it. That's primary hypothyroidism. So think of it in reverse, right? So always start with T3 and T4. T3 and T4 are down. That means TSH is up. And whenever T3 and T4 are low, it's hypothyroidism. Okay, so T3 and T4 are low, TSH is up, TRH is up. So yeah, and so that's the. I mean, I don't have to ask you about TRH, but you should know that just in case. In primary hypothyroidism, why? Because T3 and T4 are being underproduced by the thyroid gland. That will cause the anterior pituitary to increase TSH, thinking that that's why the thyroid gland is not making enough thyroid gland, that because it's not getting enough TSH, the signal that makes the T3 and T4. But it's not. It's a problem with the thyroid gland itself being destroyed. Okay, and so if TSH is up, that means TRH from the hypothalamus will also be up. Which TRH is thyroid releasing hormone. Okay, that's all this is saying. This primary hypothyroidism. Let's see what else it says. Hashimoto's thyroiditis. Okay, this is autoimmune destruction of the thyroid gland. Stuff at the bottom. Okay, so Hashimoto's thyroiditis is autoimmune destruction of the thyroid gland. You see lymphocytic infiltrate seen on the biopsy, asked on NBME. This stuff is so healed. This one right here. Okay, lymphocytic infiltrate seen on biopsy. Um, Asked on the NBME. You see anti-microsomal or anti-thyroperoxidase antibodies, and you also see anti-thyroglobulin antibodies. Woo! And so you see antimicrosomal antibodies, also known as anti-thyroperoxidase antibodies, and you see anti-thyroglobulin antibodies. You see decreased T3, decreased T4, increased TSH in primary hypothyroidism, which uh, which is the common term, like, so it's primary hypothyroidism, that's the umbrella term, and then Hashimoto thyroiditis is a type of primary hypothyroidism. um, the iodine uptake scan will be low or patchy. So iodine uptake scan will be low in Hashimoto's. Any kind of hypo, it's going to be low, the iodine uptake scan. So think of it like uptake scan is showing how much, like, so array radio active iodine uptake scan shows how much iodine the thyroid gland is taking up and how active thyroid is in making the thyroid hormone. So it just shows how much iodine the thyroid gland can take up. Okay, so just remember, it's like how active the thyroid gland is. Um, so in hypothyroidism, the radioiodine uptake scan will be low because the thyroid gland cannot take up iodine. Um, and then in hyperthyroidism, like Graves' disease, you're gonna see an increased uptake. See this down here? See, you're gonna see an increased uptake in Graves' disease. Yeah, right here. Increased iodine uptake shows diffuse the increased uptake. Okay, okay. Next, buzzy findings are waking, brittle hair, dry, doughy skin, cold intolerance. You similarly will often admit these findings because they're so easy, even though all the patients present with them. Of course, they'll admit it. Okay, so HY additional findings I've seen show up on NBME are bradycardia, 55 to 60, menstrual irregularity, dysthymia, depression, apathy, carpal tunnel syndrome due to glycoaminoglycan deposition, increased cholesterol, proximal muscle weakness with increased creatine kinase, transaminitis, but LFTs can be increased. Associated with other autoimmune diseases like type 1 diabetes, pernicious anemia, vitiligo, and immunodeficiencies like IgA deficiency. For USMLE, a big picture concept is that autoimmune diseases go together, where if you have one autoimmune disease, there is an increased risk of other autoimmune diseases. The strict HLA associations are important because outside of HLA-B27, Um, in addition, autoimmune diseases and immunodeficiencies go together, where having autoimmune diseases in general increase risk of immunodeficiencies, and vice versa. So you have increased risk of non-Hodgkin's lymphoma, uh, then oh, so you have so in Hashimoto's thyroiditis, you have a increased risk of non-Hodgkin's lymphoma. So basically, what's happening is you have an increased risk of non-Hodgkin's lymphoma, like primary CNS lymphoma if you have Hashimoto's thyroiditis. Treatment is levothyroxine or triiodothyronine, which is T3. Um, yeah, so there's a few things I want to go over here. So the reason uh, these patients get carpal tunnel syndrome is because of increased glycosaminoglycans and these glycosaminoglycans accumulate in the tissues, causing swelling that compresses the median nerve in the carpal tunnel. So, hypothyroidism causes glycosaminoglycan deposition and fluid retention in the carpal tunnel, leading to median nerve compression. Remember that? Okay. So, and then these patients also have increased cholesterol. They have proximal muscle weakness with increased CK and transaminitis. Okay, so the reason that you see proximal muscle weakness with increased creatine kinase here is be- like first of all, proximal muscle weakness. That just means weakness of muscles closest to the trunk. So you're like your hips, shoulders, right? Those are proximal to your trunk, and those areas will be weak, like the hips and the shoulders. And distal muscle weakness would be like elbows, wrist, ankles. Yeah, and then in Hashimoto's you see proximal muscle weakness with increased creatine kinase, and you see transaminitis because transaminitis just means increased liver enzymes, AST and ALT. Um, and that's because hypothyroidism slows hepatic metabolism and causes liver injury from fat accumulation and reduce clearance of enzymes. So Hashimoto's, think of things slowing down. Think of this disease slowing down almost every organ in your body. And if you slow down your liver, the liver can't do its job, which is to transaminate, and then the increase LFTs. This you will get liver injury, and that will increase the liver function. That will increase ASTs and LTs, and then you will see um, a liver function test to be elevated. Okay, all right. So AST ALT can be up in Hashimoto's. Next, elevation in TSH despite normal thyroid hormone levels. That is increased TSH, normal T3, T4. It is thought to be a pre-modification to Hashimoto's in some patients. Okay, subclinical hypothyroidism patient will be asymptomatic, hence the subclinical, and will have normal T3 and T4. Despite elevated TSH, most patients with subclinical don't need to be treated. 2CK and 3 don't treat unless TSH is above 10. Patient is pregnant or Hashimoto antibodies is positive. Normal TSH level. And normal TSH level is point. So I think the last thing we talked about was subclinical. The subclinical hypothyroidism. So yeah, this is what happens. Subclinical hypothyroidism is what happens to patients before they get Hashimoto's. What you see is normal T3 and normal T4 and high TSH. So the high TSH is what 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 makes it um, hypothyroidism. Okay, next. Hashimoto parameters: high TSH, low T3, low T4, decreased iron uptake. We know that. Mechanism for Hashimoto's: antibodies against thyroperoxidase and thyroglobulin, and antimicrosomal antibodies. So what is it? Anti-thyroperoxidase and anti-thyroglobulin and antimicrosomal antibodies. Histology of Hashimoto's: lymphocytic infiltrate, easy to remember because the non-eponymous name for Hashimoto's is chronic lymphocytic thyroiditis. Okay, so on the histology for Hashimoto's, you see a lot of lymphocyte infiltrate. Next, Treatment for Hashimoto's levothyroxine. So levothyroxine is the same thing as T4. T4 can convert into T3. So if somebody is taking T4, right? We'll get to it. But before that, maybe we'll just do it right now. Where is it? Found it. So levothyroxine is the same thing as T4, and T4 is the same thing as thyroxine. So surreptitious thyrotoxicosis is like people who take um, T4, like they take T4, it's to lose weight, and if you take that and you don't have hypothyroidism, you're injecting yourself with T4, so you're gonna have high T4, and then T4 converts into T3, so you're gonna have high T3, and if you have high T3 and T4, then that tells that means your thyroid gland is working fine. That tells your anterior pituitary that they don't the body doesn't need high TSH, so you're gonna have low TSH. That's why you have low TSH here. Low TSH, high T3, high T4, and you're gonna have small thyroid gland with a decreased uptake. But if you inject T3, T3 goes up clearly. Okay, but T4 does not go up because why? T3 does not convert into T4. Only T4 can convert into T3. So if you inject yourself with T3, T3 goes up, T4 does not go up. TSH will go down. You just have to remember TSH will go down. So basically, if the anterior pituitary thinks it does not need to help because one guy is working out of the two, he's not going to help. He's gonna rest. So the body likes to conserve its resources. Okay, so T3. If you inject yourself with T3, you're gonna have high T3, regular T4, like normal T4, and TSH will be down. Okay. So here, treatment for Hashimoto's, you give levothyroxine, which is T4. And if you see a 50-year-old male with low mood, BMI is 26, the answer is Hashimoto's. Proximal muscle weakness in Hashimoto's increased serum CK, hypothyroid myopathy. That's also seen in Hashimoto's. 45-year-old male with the decreased ability to get up from a chair unassisted and heart rate of 60. So this patient has proximal muscle weakness, right? Because they can't his hip is busted, so he can't get up. Um, because remember, hypothyroid patients have proximal muscle weakness, and they also have bradycardia. This patient has Hashimoto's. 45-year-old male with high cholesterol and high hepatic AST and heart rate of 55, Hashimoto's. Hypothyroidism can cause bradycardia, high cholesterol, high AST, thyroid cancer and Hashimoto's, thyroid lymphoma. Okay. Thyroid cancer and Hashimoto's. This is a thyroid lymphoma autoimmune disease, increased risk of lymphoma. Next. Okay. 27-year-old female gave birth to a healthy boy 6 months ago following uncomplicated labor. No weight change or mood disturbance and no medicine. Vitals are normal. Dry skin, and she has thyroid gland enlargement and non-tender. Thyroid is non-tender. UC high TSH, low T4. Okay. Most likely explanation for these findings is thyroiditis. The answer is postpartum thyroiditis. It is a type of silent thyroiditis characterized by thyrotoxicosis followed by hypothyroid. Uh, Characterized by thyrotoxicosis followed by hypothyroidism. One third of women experience both phases. One third experience just hyperthyroid phase. One third experience only hypothyroid phase. Affects 5 to 10% of women postpartum. Hyperthyroid phase usually occurs 1 to 4 months after postpartum. So yeah, hyperthyroid phase usually occurs 1 to 4 months after the baby is born. Hypothyroid phase occurs 4 to 8 months postpartum, thought to be caused by postpartum immunologic rebound. The immune system normally is suppressed during pregnancy. Okay, okay. So immune system is suppressed during pregnancy, right? So you're more prone to infections and stuff during pregnancy. So in the beginning you have hyperthyroid, then you have hypothyroid. Um, when the body attacks itself, so that's like the um, after the pregnancy wears off, um, the immune system comes to attack itself again. Immunologic rebound. So diagnosis. Diagnosis with history and ordering serum TSH, increased risk of progression to Hashimoto's. Treatment is the short course of propranolol if hyperthyroid. Give short course of levothyroxine if hypothyroid. Okay, that makes sense. All right, so somebody that has someone that has high TSH and low T4, enlarged thyroid after they had a baby. Yeah. So this patient has postpartum thyroiditis. You're going to see hyperthyroid in the beginning, then you're going to see hypothyroid. In the If the patient is hyperthyroid, you give the patient propranolol. If the patient is hypothyroid, you give levothyroxine, which is T4. Okay. Subclinical hypothyroidism treatment. Don't treat unless the TSH is above 10. What's normal? It's like zero point 0.4 to 4, sometimes 4.5. So I'm going to go with zero point 0.4 to 4.5. If anything is over that, that patient has hypothyroidism. So you don't treat unless the TSH is over 10. Okay, this is like outdated. So when I looked it up, it said 0.4 to 0. 0.4 to 4.5. So go by that. Hashimoto UBS. I think that says antibodies. Hashimoto antibodies are present, or patient is pregnant. They ask this info in CK. Okay. If you want to check thyroid function, what's the first thing to order? TSH. Want to check thyroid function in pregnancy? What's the first thing to order? Free T4. Okay. So, if you want to check thyroid function, you order TSH. If you want to check thyroid function in pregnancy, you ask for T4. Free T4. So, free T4 is the un. So, free T4 is free thyroxine. It's an unbound, active form of T4 that's in the blood that's available to enter tissues and to regulate metabolism. Total T4 is whatever is a T4 that's bound. Um, it's a T4 that's bound, and the T4 that's free, floating around. So total T4 is the total amount of T4 in your body. Okay. And that's that. So here it says, uh, like in pregnancy, you check for free T4, right? We just read it. So the thing is, in pregnancy, yeah, you do check for free T4. A high free T4 tells you if there's an excess of active thyroid hormone in the blood. It usually indicates hyperthyroidism. Most thyroid hormone is protein bound and inactive. Free T4 tells you whether the patient has thyroid derangement or not. Yes. Pregnancy and thyroid. Estrogen causes increased thyroid binding globulin produced by the liver. If you have a lot of T4, you have less free T4, less negative feedback at the hypothalamus and anti-pituitary. TSH goes up to compensate. More T4 is made. Free T4 binds to normal, but now total T4 is high. Parameters you need to know for pregnancy. Uh, if somebody has a normal TSH and somebody has a normal TSH, high total and a high total T4, and normal free T4 and normal free T3 and high thyroid binding globulin. So I guess this question is similar to whatever they were asking. So let's go through it. 25-year-old lady with one child and 10 weeks gestation and pregnancy progressing uneventfully. What are the arrows for? TSH, T3, and T4, total T4 free, total T4 ratio. Excellent. I'm gonna just do this and you do it too. So I got this wrong, but this is the answer. Oh my gosh, it is so confusing. But so what happened was in med school when we were trying to understand physiology, my teacher just said memorize arrows, like memorize what it is. Do not memorize the why, because no one's gonna ask you the why. They're only gonna ask you the what. And so one guy that I remember very distinctly, he's very smart, but his tactic was to memorize the what. And he said, yeah, I just memorize the what. I try to understand the why, but if I don't understand the why, I will literally just memorize the what. And the what is what they're always asking. And now he is a second year internal medicine guy, somewhere in New York. So yeah, it works. So just memorize arrows. So here everything is normal except for total T4. If you want to know the why, take me like forever to understand. I mean, to get to I actually don't understand this. I'm just gonna memorize arrows. But I have a chart in front of me. It's because pregnancy increases estrogen in the body, and estrogen will increase the total binding globulin, and the increased TBG will bind to the T4, which makes the T4, which makes the free T4 drop, but that's only transiently, like briefly drop. And then the anterior pituitary senses that there's a low T4, like there's a low free T4, and then the anterior pituitary increases the TSH, and then that increased TSH makes the thyroid increase the T4 production. And now you have extra T4 that is going to go bind to the extra TBG, and now free T4 is going to return to normal. Why? No. Free after the extra T4 after the T4 from the thyroid binds to TBG, that thyroid hormone, and then the free T4 also returns to normal, because I guess you don't need the T4 anymore, so it returns back to normal. And then, since the T4 returns back to normal, TSH also returns back to normal. And then total T4, which is the total T4 produced by the thyroid gland, and the total free T4 equals total T4. That is high because so much more T4 was produced because of the increased TBG binding free, binding the decrease, binding the T4, which made T4 drop, and because there was so much decreased T4, free T4, the body thought it needs more T4, so it increased the T4. And now there is increase total T4, and yeah, there's increased total T4 because of all the T4 that's been made throughout all these damn changes. So anyway, let's see. But these are the arrows they will ask you. So just remember, if somebody's pregnant, TSH will be normal, T3 is going to be normal, free T4 will be normal, total T4 will be up, and free and total T4 ratio will be down because free T4 and free T4 is normal, total T4 ratio is up. So somehow that becomes a down, a down arrow. Now this is the what I explained in like a big paragraph, and now Melman did highlight this. A student might say, "Wait, but why are you giving me above bold arrows if you just gave me all sorts of transient changes in arrows based on TBG?" It's because bold arrows are what the USMLE wants. Pregnant women who are euthyroid will have normal free T4 and increased total T4, and their TSH will be normal. The changes are due to TBG rising and are likely synchronous and slow enough that the patient's arrows stay as bold ones. And basically, he's saying that this is what the USMLE will test you on. So, if I were to ask you again, what were the changes? What will you say? Oopsies. So, pregnant lady, 10 weeks, at 10 weeks, what's going to happen? TSH, T3, total T4, total T4, and free and total T4 ratio. TSH is normal, T3 is normal, free T4 is normal, total T4 is up, and free total T4 ratio is decreased. Okay. Don't know where I left off, but the answer for if somebody's pregnant, what are the levels for TSH, T3, free T4, total to T4, and free T4 to total T4 ratio is that TSH is normal, T3 is normal, T4 is normal, total T4 will be increased, and free T4 to total T4 ratio will be decreased. That's it. Next question. This one. A 2-year-old male recently diagnosed with TBG deficiency. What are the arrows for TSH, T3, T4, TSH, T3, free T4, total T4, and free and total T4 ratio? Okay, I'm gonna do this. You do it too. I got that wrong too. The answer is normal TSH, normal T3, normal free T4, and um, decreased total T4 and increased free and total T4 ratio. Nobody knows why, but that's the answer. Um, yep, just make a note of it, memorize it. Don't know what to tell you. I just know it's high yield. This is TBG deficiency. Okay, TBG deficiency. So, this is the answer for that. So,
for lunch every single day. But don't worry, I'm not an animal. I use sauce. My sauce of choice right now is a sweet and heat mustard. It's only 10 calories. And I'm typically too lazy to dirty another dish, so we just squeeze a little sauce in the corner, give her a little mix, and bon appetit. Now dinner. Dinner is what I wait for all day. All my other meals are boring, so I have a massive, stunning salad. I got spring mix, shrimp, blue cheese, strawberries, apples.
so in TBG deficiency, you have normal TSH, normal T3, normal free T4, decreased total T4, and increased free T4 to total T4 ratio. Just memorize that. Nobody will ask you why. So next one is this. What do you think the answer is? So 25-year-old lady has one kid, pregnant with her second child, and gave birth 8 weeks ago. No complications with pregnancy or labor, no past medical history, 4-day history of tremulousness, tachycardia, and heat intolerance, or the arrows. Okay, let's see. Okay, I got this right. Feeling happy. This is postpartum thyroiditis. Patient is hyperthyroid. Condition can present as hypo as well. So this patient is hyperthyroid. So you have decreased TSH, increased T3 and T4. Remember we talked about this hyperthyroidism. You first start with the T3 and T4. If that's up, TSH automatically is down. Remember we said it's a decreased rate uptake for this. The uptake is low even if the patient is hyper. Same like uh, Descartes thyroiditis. Okay, we covered all the TBG stuff.